Everybody, it is 2 o'clock. So welcome to another Health and Wellbeing Board meeting. I'll just do apologies. Just let me bring them up. So we've got replacements for this meeting. We've got Sarah Callahan in for Edwina Grant for LCC. We've got Jerry Hawker in for Jeff Jolliffe from Morecambe Bay CCG. I'm also told we've got a further apology from Adrian Leather, which has just come in. We've got Gary Doherty in for Peter Gregory, Westlanc CCG, and for Karen Partington at Lancashire Teaching. Sue Stevenson for David Blacklock for Healthwatch. And then apologies on top of Adrian's, we've got Gary Hall representing the Chief Execs, and Steve and Ashley for Adults and Children's Safeguarding Boards. And I think that's about it, Sam. Is that right? Pretty sure it is.
Yep,
yeah.
That's it.
Okay. So with that in mind, we'll move on to disclosure of pecuniary and non-pecuniary interests. We all okay? We seen the agenda? I'll take that as yes. Then we've got minutes of the last meeting. I presume we've all seen those. Any questions or comments on them? Good. That's good. No comments. So that takes us on to the action sheet. To note the action updates from the previous meeting, the forward plan for future meetings. Any comments on those? No, I don't think there's anything pressing there. Sorry, I'm late. Yeah, I can see that. That's no problem. Buckle in. So if we can move then on to item 5, which is the SEND subcommittee, and we've got Sally to present on that one.
Actually, Chair, it's Sarah. Sarah Callahan, who's representing Edwina Grant. I'm also updating on this report, if that's okay. So you should have.
No problem.
Is that okay? Sorry.
Yeah.
So you should have in your packs a report from the minutes of the last subcommittee. So the subcommittee to the Health and Wellbeing Board that oversees and scrutinises the progress on the 5 areas that's still subject to monitoring and challenging as a result of the SEND inspection in March. We've now had 2 checkpoint meetings with the NHS England and DFE. The last one was last Thursday, where we shared the updates that were shared with the subcommittee on each area, and we've had positive feedback. Sorry, I seem to have a bit of an echo there, apologies. So there's no risk to delivery that we identified at the last subcommittee. We've got positive feedback from the checkpoint meeting, and really the report just shares the fact that good progress has been made in each of the 5 areas. So I can take any further questions if you want me to add further detail, but there was thorough scrutiny and challenge at the subcommittee meeting to each of the areas. We RAG rated each of the updates so that members are clearer about where we need to focus our support moving forward. And we had, you know, a good level of challenge and debate. So, yeah, I'm happy to take any questions on each of any of the 5 areas if it's helpful. But generally, just to report that there's positive feedback.
Yeah, thanks, Sarah. I've got Philippa's hand up, and myself and Philippa are on that board, and I can confirm what you're saying is absolutely true. There is plenty of challenge on there, which is good, and we did make some changes to the, like you say, the RAG ratings, the dashboard side of things, to make things look a little bit easier to follow it. So they were all good. Philippa.
Yeah, just to echo that, and really just to say that I think it was a really good decision of this board to create that subcommittee, because it really is enabling us to properly scrutinise what's happening and support the team in delivering the plans, and just to recognise that I think it really benefits from the non-executive representatives from the CCGs on the subcommittee as well. A fresh fresh perspective, and it's all to the good. So thank you.
Yeah, and again, I echo that. I think it's really useful, and will certainly help us to monitor that going forward as we plan to get to good. So that's all good. Any other questions or comments? No. Okay. Well, thank you, Sarah, for that, and Philippa for your comments. We'll draw a line under that, and we'll obviously come back with further progress as it's made. And like Philippa says, I think it's a smart move that we've done that, created this subgroup, because we can keep a real eye on it. So that's all for the good. Okay, we'll move on now. A bit of a meaty one here, which is the item 6, the national consultation for integrated care systems. And I think we've got Andrew in to present, and then we'll take the questions and comments thereafter. Andrew.
Thanks, Chair. Hi, everyone. If you don't know me, I'm Andrew Bennett. I'm part of the exec team for the integrated care system. I've been asked to come and introduce this national process that kicked off at the end of November. So just to say, in your agenda, you have a fairly short cover paper. It refers to this national consultation that was launched by NHS England and Improvement 2 months or so ago. There is a link in your pack to that national document, but we also put a summary slide set there for you, which hopefully is quite a good summary of the main proposals in the document. They launched the consultation before Christmas, and it ran until the 8th of January, so it's just closed. The outcomes of that process are still awaited. So as we start to talk now about some potential changes, I have to say right now that those are subject to the outcomes of the consultation and a process of legislation through Parliament. So we're not running too far ahead of ourselves here, but we're obviously happy to talk about any of the issues or questions you might have. There are some important proposals in here for the way that we work together. But I think I ought to say, by way of introduction, that this does feel like a story of continuity, really. I've been to the Health and Wellbeing a few times over the last few years, and the story of the NHS working with local government, with the voluntary sector and with local communities, this idea of integrating care, joining care up around communities or neighbourhoods or the place-based partnerships, or for some of the work across the whole of Lancs and South Cumbria. That's a story that we've been developing for quite some time, and is picked up in the national policy proposals. And effectively, the consultation is saying there are some further ways in which we can strengthen collaboration in those working arrangements. I hope you can see in the cover paper, the focus, the purpose behind the reforms is directly relevant to health and wellbeing boards. So there's a reference to improving population health and healthcare, tackling unequal outcomes and access, enhancing productivity and value for money, and enabling us, I think, within all of our main organisations to support social and economic development. And if those things were vital before COVID, they're certainly mission critical now, are they not? So the purpose behind any of these changes is set out quite clearly. Effectively, the documents begin to pull out the development of an ICS, an integrated care system, and make it a statutory body, or put it on a statutory footing. And when we were reading that, we were very conscious of the fact that the ICS is much more than just NHS organisations. It really is important that we emphasise that. But the proposals here would take us forward on a Lancashire South Cumbria level and potentially give us a number of statutory functions. But then also in the document are the collaborations that we've got in our local places, the integrated care partnerships that you've heard about before, and also the collaborations of our provider organisations. Now, some of those can happen in an area like Central Lancashire or Pennine Lancashire, Morecambe Bay. We've got colleagues from all those areas here today. But some of them, and we're seeing this coming through the COVID experience, are about our hospitals or mental health services working together across the whole of the patch. So that collaboration is not restricted, and it's generally there to be encouraged. The papers have two options. When they were consulting partners, they had two options. One, to create an ICS with a single CCG as part of it. And the second option would be to have no CCGs, but to transfer some of the functions that CCGs have had in the past and integrate them into the role of the ICS, with the potential for some tasks that have previously been undertaken by commissioners to be delegated to providers. So there are a number of elements in there that they wanted feedback. And the ICS made a response, some of our individual organisations have made responses, some of our partners, partnerships have made responses, and I think local authorities have done as well. So I am fairly sure there will have been quite a significant response to this set of proposals nationally and across our patch. In terms of going forwards, I think we feel there are some important areas that we need to focus on, particularly in terms of working with local government, having really clear shared priorities. And I think that's where health and wellbeing boards are important for helping us to agree those. Being clear how we demonstrate the benefits of these collaborative relationships. And again, COVID has demonstrated that where you're taking decisions locally, you can often do those with a real understanding of the communities and some agility as well. So that's quite important that we draw that through. And I know that many of our local government colleagues are committed to working in those place-based partnerships. They see that as an important part of the work we do. Lastly, Chair, and then I'll stop talking. I think we're conscious that we've got further obligations to explain any changes to members of the public, to elected representatives, to our staff as they come through, as we see the proposals developing this year. And also to be conscious that there is still a level of public accountability here. So one of the responses that we've made to the consultation was to say it's really important that we're clear what we're expecting of partnerships by way of accountability, but also for individual organisations to retain their accountability to the public. And one demonstration of that in Lancashire and South Cumbria has been the board of the ICS beginning to meet in public from December. So those are elements of the story moving forwards. So that's the introduction. I hope the papers were relatively clear in your packs. I'm happy to take questions, but I'm sure other colleagues will also be happy to give their perspectives on this. Thanks, Chair.
Yeah, thanks, Andrew. And I will open this up. I did make my comments because I'm a board member of the ICS board, and I'll just quickly race through them. I'll not go into too much detail, but generally welcome this. You know, integrated working, and it's been underscored by the pandemic really, and the need to do much more of this, and it's brought into sharp focus some of the health inequalities. The big caveat for us currently is the pandemic, so the timing isn't great in terms of even discussing system reform. So absolutely welcome it, the principles generally, but facing up to this at the moment is tough. I also made the point that I think I would like to explore much more what we can do without necessarily changing anything. I think I look back to 2017 and the twilight of that year when I came into this role, and we had a meeting at that point with NHS partners, a reset meeting, if you will. And I think the ground we've covered since then has been really good. You know, to get things moving again, we had this meeting about let's start again, draw a line, and let's see where we can go. And that's been really good. But I think there's much more we can do. And I think, you know, even in the current form we're in now, not that I'm saying it doesn't need some changes. Andrew mentioned that there's a lot of stuff that the Health and Wellbeing Board covers, you know, in this, you know, population health, etc., etc. I was just a bit disappointed that there wasn't reference directly to health and wellbeing boards, who, as we know, already have statutory powers. And when it comes to making some of these decisions, we need the accountability. With the devolved decisions, we need that accountability. And I think the Health and Wellbeing Board can offer that, because it's got the right representation. And I think I'd like to see that much more involved in this going forward, because as Andrew rightly says, it's made up of all sorts of partners. So that's one issue I've got around accountability. And I suppose the other one is to do with finance. We have obviously the NHS deficit for across the county. It's currently, I think I can say this is around £300 million. It's a perennial problem, and there's mention of pooling pots there, which I'm a big supporter of if we're going to do the right thing, because the onus on us all then is to make those decisions considering everything. So I am a supporter of that. It will be difficult to get to that. There'll be a lot of work to align that and make that happen. But we also have to understand any impact on area deficits and how that would affect the overall budget in a given area. But as I say, welcome the general feel and principle of it, but there's certain things we've got to work through, and I think we could do much more even now, because since, like I mentioned, 2017, a lot of the stuff we have brought forward has been the easy stuff, and we sort of hold off from some of the harder stuff. I think the pandemic has made us face some of that harder stuff, and I think it's also shown there's more we can do. But I'll open it up. I think I've got one hand up for now, which is Sue Stevenson.
Yes, thank you, Chair. Members of the Health and Wellbeing Board will probably remember who were there. About 2 years ago, I brought a presentation from Healthwatch about the experiences of people across Lancashire, South Cumbria, and there was many comments at the time like, well, gosh, that hasn't changed since last time. What are we doing to address some of these very well-known and very well-rehearsed challenges? And I suppose my plea over any structural change is always, okay, that sounds like a good idea, but please convince me that it will mean that it's more likely that some of those long-standing challenges that people are facing in our communities are more likely to be addressed. And, and in a very general way, does that mean that we will absolutely see more engagement and involvement? Does it mean that we will see more person-centeredness, if that is a word? And does it mean that we'll see improved patient care? Because inevitably, when there's a structural change, everybody around this table and across the ICS get involved in writing the strategic response to the structural change and thinking about what does that mean for roles and responsibilities within the system. And we forget sometimes that actually what this should be about is delivering those things I've just talked about. So, it's a big question, but, any structural change has to be around improving what we're all in business for, which is patient care and involvement. And I'm just struck by the comments that were made by the board, as I say, I think it will be 2 years ago, Chair, when I brought that presentation. And so my request is, let's not forget that we need to make that central to the mechanisms we put in place to address the change, if indeed it's agreed to go forward.
Yeah, thanks, Sue. Absolutely. And I suppose one thing I didn't mention as well was local government review, and that's sort of held in suspension at the moment. And that's another big consideration, I think, before we start tinkering too much. I'm wondering if anybody else wants to come in with a question or comment. I was wondering whether is Louise on? I know Graham's on. I can bring Graham in. Graham. You're on mute, Graham. It's got you again.
Gotcha, thank you. Yeah, good afternoon, everybody. Yes, the thing that we're aiming for to get an integrated care system so it works better, more effectively for people is absolutely right. I was disappointed that this came from National Health England and not from the Department of Health and Care, because it just seems that the National Health nationally are addressing this to the National Health locally and following their own structures. And I think this is unfortunately about structure alteration in the National Health Service. And I think local authorities, care services have been tacked onto the side, and I don't think there's much integration in this at all. I also think there's a complete democratic deficit. As you say, as it says in the report, accountability across systems to Parliament. Now, this has always been the problem, that there's no elected representation on this until it reaches a minister in London. And we've got all the local MPs and all the local authorities, and there are a number of them, who don't seem to have any role in this other than as a member of absolutely massive board that's been suggested as one of the options. I think we need to go away from this. I think we were handed 2 options and that was it. I think there are many more options and we need to look into this. I mean, as Sean said, there is the matter of local authority reconstitution, as it may be, but the way things are going at the moment, as William Pitt said, you can put away that map, you won't need that for 10 years. Because a lot has been learnt about how we work together and how local government works from the pandemic, and we can learn a lot from that. I would also like to wait until all the work done by Newton Europe is presented to us at the conference on the 10th of February and see what other schemes, other ideas there might be. I'm not content with being offered just 2 options, and I think a lot more work needs to be done on this.
Yeah, thank you, Graham. Absolutely agree with that. And it would be prudent to see what Newton Europe come back with, I'm sure. I've got no other hands up or requests for comment. Oh, Louise has put her hand up. Go on, Louise.
Yes, Chair. I felt I ought to give reference to me by name, so I didn't want to appear that I was silent on this. So just a bit of context for the benefit of all board members. So as part of our response to the COVID pandemic, you will be aware, because I have previously referenced it here, that we have stood up a social care cell, which ostensibly is around focusing our response to meeting the needs of vulnerable adult population. That's not to say that children aren't vulnerable, but this has been stood up specifically to deal with the response to the care sector. So we did look at this consultation document. I won't cover much of what Graham said, other than to say it's not an unexpected document to have arrived. It is disappointing in the fact that it was absent on, I think, capturing the wider panoply of partners that make up an integrated care system. And disappointing that, yeah, it came out through NHS England when it could, as Graham has said, come out as a partnership document, and perhaps given us more of an opportunity to talk specifically around the options. And I think the strengths that have been evidenced through this pandemic, because I think things I would say, there's been great strength in partnership in a very difficult and challenging situation over this last almost 12 months. Emphasising, I think, the strength of having a place-based approach, because all of what we've done has been delivered at the places close to where people live and work. And I think it's illustrated the challenges that we face, and which I would recommend this board should be taken as a key priority this year around population health. It can be no coincidence that the areas where we have seen the highest level of incidence of COVID infection have been in those communities where we know we've got greater levels of deprivation, challenges related to housing. So, Sue, I'm absolutely, if we are here to improve the health outcomes, which we are, and the wellbeing outcomes of our citizens, then I think this has emphasised the importance going forward of a population health approach. And I'm sure there are colleagues on, Julie Higgins being one, who's leading for the health and care system on population health, and why I would commend that we do look at that going forward. So disappointing as it is, I think we have a responsibility as senior public officials to say, well, how do we make our system work in Lancashire, South Cumbria, for the benefit of those who need to access services, building on the strength of what we've achieved in this last 8 to 9 months. We've moved further on some things than I'd ever thought was possible, to be honest, because I think we've galvanised behind a common purpose. What I would be very disappointed in is if we lose momentum on those things and revert to some of the traditional ways of working that we saw pre-COVID. inevitably I've got to be honest, Chair, and say why it has been easier is because one of the main sources of barrier and frustration is to do with funding, and that's where we probably spend a greater level of time deliberating at risk to the public, really, if I'm totally honest, isn't it? But it has made it easier, and it's made it easy because the funding has come in through one direct route. And as Graham said, in the absence of the paper that we've got on social care funding, we're probably still going to have to muddle our way through the future, but we've got to build on the strengths of what we've done so far, and take this as an opportunity and shape it to the way that we want it to be in Lancashire, not the way probably centrally they expect it to be, because we know the place and our population better. So thanks, Chair.
Yeah, thanks, Louise. I mean, I think the worst possible scenario would be to run ahead with one of these options and then tag local authorities on again onto the side. I think we've got to be. That would be a big epic failure, I think. So Andrew, I don't know if you want to come back on any of that, or have you duly noted it?
I will say one or two things, but Dennis has got his hand up, Sean. I wonder if you would mind bringing him in, please.
I will bring Dennis in. Yes, Dennis. I think you're on mute, Dennis. I can't see you, but I'm just guessing.
I think his line might have frozen, actually.
Yeah.
Sure.
In the
Sarah's
meantime,
got a hand.
Sorry, Gary's got his hand up as well, and Sarah. Sarah was first, Gary, so we can just let Sarah come in.
Yeah, thank you. It was only to add to, from a children's perspective, some of the messages that Louise has said about a place-based approach, you know, and the issues that have been exacerbated by COVID. We know that, you know, in our infection rates in schools, they're more prevalent in those areas that are also more deprived. And we've seen a 22% increase in the eligibility criteria for free school meals. So I just think the principle underpinning that place-based approach obviously is a sensible one. And we have redesigned our early help service, children family wellbeing, and also our education services on the ICP footprint, so that we can better collaborate to both target and meet need. So whatever footprint it ultimately looks like, being able to work on one that is consistent and supports us to better respond in a collaborative way makes a lot of sense, doesn't it?
Thank you, Sarah. I'm going to give Dennis another chance. 3 strikes and you're out, Dennis. Still nothing from Dennis. So I'm going to bring Gary in.
Thank you, Chair. Just to emphasise a couple of points and then just make one kind of extra point. Probably just worth noting that there is more detailed guidance expected. It's referred to in the documents, and I think that will be helpful because, like you, Chair, and I think like all of us, the broad direction of travel I think is a very good one here. You know, we'll need to get into some of the detail, and some more of that detail will follow. Absolutely echo Louise's points about the local place-based work. That I mean, I've not been here that long, but I think, you know, that last period I think has really accelerated some of that partnership working, which I think is fantastic. But and also some of that work across Cumbria and Lancs, across different organisations, across, you know, I was in a meeting, chairing a meeting earlier on this afternoon across myself and all the acute hospitals in Cumbria and Lancs, are trying to make sure that we're able to use the kind of resource we've got in terms of critical care beds to make sure that, you know, cancer patients and other patients that, you know, are not disadvantaged because of the particular circumstances of their patch, which can change, I have to say, from week to week. So I think on both the levels kind of identified in the document, place-based kind of working together, kind of regional or whatever we want to call it, kind of working together. I think the last kind of, unfortunately, the last kind of, you know, period we've been in has meant we've had to do things, but I do think it sets us up well now for this kind of direction of travel going forward, particularly with some of that further detail still to come.
Thank you, Gary. And I'll try, I'll go for Julie because Dennis has disappeared altogether now. So Julie.
Thank you. I just want to sort of follow on really with some of the comments that Louise raised, and about how how we can really make a difference and do some positive things if we work towards this guidance, particularly around place. And I think that, I mean, I've been a director of public health so a long time ago, and I don't think I've seen an emphasis from the NHS on health inequalities at the level that we're seeing now. And if you think about our population, our COVID response that we've had, because we've had a lot more COVID because of inequalities. And as we move out of this, we will have significantly more inequalities. I think that this actually signals to us in the NHS to work with our partners to make a difference on this. And I think that I know we've got some really good work that's happened, but I think the emphasis and the energy that we can put into it will be really increased. And I also, the other part that's coming through very strongly is about how we in the NHS need to galvanise our employment and procurement capability to make a difference to our local areas. And the ICS and the ICPs will be able to do this with a great deal of energy. So I am leading on behalf of the ICS some work on health inequalities. Again, it is obviously been affected by COVID with in relation to our ambition. But what I want to do is to work with leaders so that we land this really centrally, so that when we have reached herd immunity, we can move forward very fast on some of our ambition.
Yeah, thank you, Julie. I could echo that. And I hope this has been worth waiting for. Dennis has come back again. Dennis, I'm going to bring you in.
Yeah, can you hear me?
Yeah, I can hear you now, yeah.
Oh, thank God for that. Sorry about that. I'm not so sure you need to wait with bated breath for my points. I'm going to be very brief. Just wanted to just respond in support of Councillor Gooch and Louise's points from earlier on in the discussion. Just a couple of quick thoughts. Councillor Gooch was absolutely spot on that this is a bit of an unusual way forward. Well, certainly unusual for us in the health system, because we're used to policy coming from central government that we have to implement, whereas this is a recommendation that's come from NHS England itself. I'm pretty sure we should expect to get some operating guides that come in due course, which I think will cover a lot of the points that have been raised about, the proper connection with the local democratic leadership and local authorities, etc. Just responding to Louise's point, which is another point, a good set of points that she made. It's up to us now in where we are in Lancashire and South Cumbria to start to work up the place-based leadership connections, and it's up to us as leaders to start to make those more potent than they've been before, taking into account that we will have some form of delegated budgetary control at local level. We don't exactly know what that is going to be yet, but we will have it. And it's up to us now to start to fashion a leadership connection that's going to make a bigger difference than what we made before. I'm quite positive about what's going to happen from now on, but I think there is a little bit of wait and see to see what the operating guide that comes with this. Thanks, Chair.
Yeah, thanks, Dennis. And I think that draws to a conclusion the hands up and any request to speak. So I'm going to go to Andrew. Maybe you can come back on some of that, Andrew.
Well, just briefly, Chair, the useful discussion, even though it wasn't a lengthy one, because actually none of us really want to see change for change's sake. I think most of us would believe that you're right in saying that we should be able to get on and show to members of the public that we can work effectively. And there's some really good evidence of doing that now. But these reforms and any others are going to be based on whether they improve health, improve outcomes, reduce some of the fragmentation that people often talk to Sue about and other colleagues as well. So we'll carry the story forwards once we see the outcome of the national process and any proposals that go into government at that point. Come back to you on that one. Thanks.
Brilliant. Thank you, Andrew. That's most helpful. And that does draw to a conclusion, that item. And like Andrew said, there was some useful discussion there. And yeah, the general feeling is not against it in principle at all, but there's some fine tuning that needs to be done, you know, ahead of any system reform, I would say. So that takes us on to item 7, which is Sakthi, who's going to give us a quick update on COVID.
Thank you, Chair. Afternoon, everyone. Hope you can see my screen. Can Sean confirm that?
I can.
Yep.
Thank you. Good afternoon. Before I even start, I just wanted to pay tribute to the staff working across our agencies, both frontline as well as people in leadership role, for their continued effort, which is incessant. And I just wanted to recognise all of your leadership and a big thank you, and also pay tribute to the families who've been affected by COVID, especially those who've lost their loved ones. Although COVID can affect anyone, who it does actually affect is very striking in terms of those that are living in vulnerable conditions, or indeed have some certain characteristics like BAME, and particularly older people. I'm going to give you a very short summary of the situation as it currently is. The data is 4 or 5 days older. That's the most complete data. What you're seeing there is the age group based incidence. As you move from the bottom of the slide to the top of the slide, the age group increases. And as you move from the left to the right hand side, it's a timeline from middle of December to where we are now. And darker the color, higher the incidence rates. And this is across the 3 upper tier local authorities, Lancashire, Blackpool and Blackburn and Darwin. The rates are very high to start with, although the actual numbers have started to show signs of decreasing in the last 4 or 5 days. That hasn't been captured in the most complete data. So some glimmers of hope in terms of the impact of lockdown and how people are behaving, but the rates are very high. We've never seen such high rates. And particularly, well, this is a breakdown. I don't expect you to see the numbers there, but this is breakdown by district. And as you can see, it's very dark in many places, particularly in the east, and certainly darker in younger age groups. And that's of concern to us. If you look at Pendle, Burnley, the rates are like over 1,000 cases per 100,000. And the worry is that inevitably it's going to catch up with older people. And the only game in town now is the race between the virus and the vaccine, which we hope will have a significant effect as we go into the next month. More and more people in the top 4 groups, priority groups of the JCVI, the Joint Committee of Vaccination Immunisation, will be vaccinated. So a pretty sort of bleak picture in terms of the cases as we have it. But as I said, the numbers, the overall numbers are starting to show a decline in terms of cases. And this is the overall picture across the county. The situation regarding the hospital, we haven't seen a similar decline yet. It is very stretched, particularly critical care. Occupancy levels are really high and increasing, certainly in the east. Likewise, we're seeing more and more incidents in the care sector. There has not been a decline in the health and care utilization like there has been a decline after the wave 2, and then it went up again. And most of that is after the Christmas break. We anticipate that the NHS situation is going to improve. It'll take at least another 3-4 weeks, if you're lucky, slightly earlier. So all this is managed regionally, and the critical care is also part of the national network. There are 3 main sort of priorities or key parts of the strategy, if you will. The first one is the ongoing engagement with various community groups in helping them, supporting them to follow the rules and guidance and so on, where necessary, and enforcement. The second main one is in the order, not in no particular order, is testing and finding the cases and supporting them to stay at home, especially positive cases, in good time, and supporting them through the hubs with food and medicines and so on. The most significant one is actually the vaccine program. We are getting very positive signals about the numbers of doses being given. We are a bit hampered in terms of not knowing the, again, going back to some of the conversations that we were having, and not knowing the inequalities and the variation in terms of vaccines uptake. And my concern, and shared by many of you on the call, is that there is a significant variation in our patch. And when we get the data, it probably will be another couple of weeks down the line. So we need to anticipate that and be prepared for addressing that fairly quickly. The wider effects of the pandemic is also, it doesn't have to be described here. You will all be very familiar with that, but we are picking up some of the fundamental issues, like the demand for food has increased. Homelessness has been an issue, and it is showing signs of more capacity needed for temporary accommodation in parts of the county, particularly east. Surprisingly, the Valley, actually, last time we've looked at the figures. So the outlook appears to be that there has been an effect due to the suppression of the lockdown factor. We anticipate that the cases will continue to decline, but it will take a bit more longer for the vaccine to actually show effect in terms of hospital admissions and deaths. It's estimated it will take at least 10 to 21 days after someone's had a vaccine to have that effect of the vaccine. And if you think about the timescales in terms of when we anticipate the top 4 groups to get vaccinated, and they are the most significant groups, the aim is to get that done in a month's time, by middle of February. And if you add another 10 to 21 days, and roughly a month, middle of March, end of March, probably when we will know the impact of vaccines. So until then, it's basically hunker down, protect the vulnerable, hand washing, and all of that, stay at home. And particularly if you're symptomatic, get tested. And another big program of work you'll be familiar with is that we are scaling up the smart testing, or the lateral flow device testing, which basically is repeat testing of individuals every twice at least in a week, particularly in workplaces, increasingly also being rolled out in the community through community organizations. So people who can't work from home and have to go out get the opportunity to get tested on a regular basis. And that is likely to become a feature as the lockdown gets lifted. So testing and vaccines the first priority, and testing immediately after that, and tracing and isolation as the main strands of work, whilst the engagement needs to remain in place, particularly in terms of addressing inequalities. With that having said, there are a couple of uncertainties in terms of effectiveness of vaccine, particularly on reducing the transmission of the virus. It's well known that it's going to reduce the severity and the hospital admissions. In real world effect, we will find out by end of March. And then obviously the virus itself, those are a couple of uncertainties, and until we really get past those points, it will be some form of restrictions. And we anticipate that we will be moving down the tiers of, or the gears of tiers, as they are famously becoming known, from lockdown to some sort of tiering as we enter March, middle of March afterwards. So it's going to be a real heavy lift, and it does feel like we are on the last leg of this, at least the current turbulence that we're facing, subject to the virus not changing. We should be, and the seasons will be in our favour as we go towards spring. So that's the plan now, and that hopefully will give you a picture of what's going on at the moment. Thank you, and happy to take questions.
Yeah, thank you, Sakthi. I'll open this straight up. I've got Graham wanting to come in? You may be on mute, Graham. Again.
Yes. Oh, sorry about that. Yeah, I'm very pleased with the way that the immunisation has gone on in the care homes, and we had 70% by the end of last week, and I understand it will be 100% by the end of this week, which is a great thing. Now, another part of my portfolio is learning difficulties and autism, but unfortunately, people living in supported living seem to have been not on the radar as an important part of it. So obviously, as everybody knows, people with learning difficulties and autism often have underlying health problems, which means there's greater mortality amongst them, but they don't seem to have been identified in stuff coming from government as a priority group in the community. And I wonder, can we address that in some way? We've written to the Under Secretary of State, but I wonder if we can add any emphasis to this.
Sakthi, do you want to come back on that now, or do you want to come back on all the points?
Either way, Sean, I'm happy to wait.
Okay, we'll do it that way. Okay, so note that one. Next one, we've got Julie.
So I just want to make a comment on the inequalities in vaccination, because there is very little data, but we have been trying to pull some data up from primary care and have a look at it. And even if we look at inputs, so the number of vaccine drops that we've had, the way that we established ourselves, which was the right way to establish ourselves, was to establish large sites. But then what we've had is delivery of vaccine per site, which means that some of our areas with the greatest health inequalities, such as Burnley and Blackburn, have had less vaccine per population. So we are monitoring this because we are concerned about creating greater inequalities. And we're going to have 2 mass vaccination sites in Burnley and Blackburn, which are coming online, which we hopefully would make a difference, although we are concerned about elderly people going to mass vaccination sites who would rather go to their GP. So we are closely monitoring what we've got. We're expecting national data to come through really quickly, so we'll be able to kind of verify our local data with that. And we have been working closely with Amanda Doyle to be clear that you know, that we get extra drops, and that we, if anything comes online, such as pharmacies, that we can put these into our areas of greatest inequality. What we don't know, but we suspect, is that we've also got some inequality with minority ethnic groups. And so I've been through our out of hospital response that we've got in Pennine, we've been speaking to the local councils. I had a conversation with the Burnley Chief Executive earlier this week about how they can how local councils can help with community engagement with communities. And so we're seeing that mobilise as well, which hopefully will have an impact on those groups who are less inclined to come to vaccinations, so we can get some really positive messages out there and dispel some of the myths that are out there as well, which are discouraging people from coming forward.
Okay, thank you, Julie. I'm sure Sakthi will pick that up. Margaret Prance, please.
Thank you, Chair. Yeah, I just wanted to ask, am I correct in what I've read, that the testing only actually identifies about 50% of the asymptomatic carriers, or the people who are going into work otherwise without any symptoms? So if that's the case, there's a danger that it will instill a sense of complacency, perhaps, when people think that they're clear of the disease, when in actual fact they've only got a 50% chance of being actually clear of it, even though they're testing negative. Thanks. That was my question.
Yeah, sorry, I was just having trouble unmuting then. And I'm going to bring Sakthi back in to take those. Just while I remember, one apology I forgot was Councillor Driver, who unfortunately couldn't make today, and I didn't put that in the beginning, but I've put it in now. So Sakthi, I'll bring you in.
Yeah, I'll take them in the reverse order. So Margaret is right about the accuracy of the lateral flow devices. It doesn't have the same accuracy as PCR tests, and that's why it's important to have repeat tests. And as we repeat a slightly less accurate test, the chances of it picking up positive cases are higher. And that's why it's important to still maintain COVID secure workplaces, social distancing, all the other rules, and wherever possible work from home and so on. However, it does give us the additional capability to find cases otherwise wouldn't have been detected, and that's the rationale for introducing lateral flow on a large scale. It shouldn't be misconstrued as test to release at the moment. It's test to find cases. And we will keep it under review, and the technology it does change over time, and it's going to be rolled out in a number of settings as well. So we will pick up the learning as we go along. But the way that we've organized the testing, which is very different to what was initially there in Liverpool, where anybody can go and get tested. But what we're doing is really targeting and repeating tests and a captive population, if you will, in workplaces and people that require tests on a regular basis. So that's our kind of, in a way, safeguard, but it's never 100% and no test is 100% accurate. But we can mitigate those risks with concurrent messages and engagement in a way that people understand the test results. On the the vaccination inequalities is not a new public health issue. It is a perennial public health issue, often not helped by hesitancy or misinformation, and there are funds available for community champions that's gone directly to the districts, and we will be working with each of those districts where there's high proportion of BAME groups or any vulnerable groups, so that the local connections are there to address the barriers. But supply and the way that we've organized the centres to be able to draw down the doses does appear to be playing a role. And we just have to, especially given East is more affected and the hospital's very stretched there, it looks like that's where the issues are going to be as well in vaccination. So we really need to have a close eye on that. On the LD, learning difficulties and autism and other groups, the JCVI prioritisation, we do not have any room to influence at all. And they appear to be quite rightly based on the priorities are based on age and also the clinical risk factors in terms of extremely vulnerable groups and the frontline health and care staff. People with learning difficulties and autism, if they have got other conditions that would make them vulnerable, they will be captured and invited for that. But we are getting quite a lot of representation, and this is one of the main groups. We know that people with learning disabilities have got much shorter life expectancy. Homeless is another example. We are making representations, but it is not for now. Certainly, it would appear that once we get past the first 9 groups, there may be a room for local prioritisation, but we don't have any room for influence on that. Having said that, we have made these lists available to colleagues in the NHS who are leading the vaccination programme in the context of them having a reserve list, if you will, at the end of a day, where there are going to be some doses left, rather than wasting them, it'll go into people's arms. And people are taking these lists and calling them. It will be a bit haphazard, but overall, on a population level, we do seem to be doing actually better than our neighbouring areas in terms of vaccination uptake. But point well made by Councillor Gooch there, and we will continue to. And there are other groups who are, by nature of the national policies, having to work, like nursery staff, early years, private voluntary institutions, getting a range of representations from them. But we're collating them, speaking to, liaising with our local NHS colleagues, but also informing the national policy. So that's our current stance on that. I think I've answered all the queries so far, Chair. Happy to take any further ones.
Yeah, no, I think you have there, Sakthi. Thank you. We haven't got any further ones. So thanks for that and for the info and the work you're putting in, which I know is not quite 24/7, but not too far away. So on that note, I'll draw that to a close. Take us on to urgent business. I'm not aware of any urgent business, and I don't think Sam will come in and tell me otherwise. Which takes us on to the date of the next meeting, which is the 9th of March 2021. At which point I'll be 7 days over 49. So my birthday being on the 2nd, and I know we're all meeting virtually, but you can still post presents. That's still allowed. So I'll look out for those. But thanks everyone for coming, and I will speak to you all next time. Okay.
Thanks everyone. Take care.
Thanks,
Bye-bye.
Sean. Bye.
Thanks a lot. Bye.
Thank you. Bye.
Thank you. Goodbye.